it is correct to say... Oh, this is better, right? I had the feeling all the time. I hope you did understand me at all. So it is correct to say that two simple morphological methods, namely X-ray of the mammary gland combined with histological assessment of needle biopsies, saves lives in patient care day by day. In the second part of my talk, I would like to switch the perspective from outside to inside pathology. I would like to show the spectrum of lesions encountered in diagnostic breast pathology, and I would also like to try to rank the relative difficulty of certain differential diagnoses based on the frequency of submissions of such specimens for second opinion consultation from local institutes in Lower Saxony to our reference pathology unit at the MHH. Well, the subtyping of invasive breast cancer as NST, no specific type, or invasive lobular breast cancer or any other special histological entity is felt to be basics and straightforward by most pathologists. And that's why specimens with this differential diagnosis are very rarely submitted for a second opinion consultation. The assessment of intraductal epithelial precursor lesions or epithelial proliferations as either reactive and hyperplastic versus malignant and breast cancer precursor can be difficult on some occasions. And that's why this is indeed a topic that we see in second opinion consultations. Importantly, however, the spectrum of tumors in diagnostic breast pathology also includes mesenchymal tumors, or spindle cell lesions as the pathologists call them. And the differential diagnosis in spindle cell lesions can be very difficult. This is because these tumors are rare. There are many different entities. And importantly, tumors with benign behavior, such as the myofibroblastoma shown here on the left side, and malignant behavior, such as an angiosarcoma shown here on the right side, can have a quite similar morphological appearance. And this is why differential diagnosis of spindle cell lesions is actually one of the top-ranking subjects among second opinion consultations in our reference pathology unit. This may be surprising for you because the mesenchymal tumors of the breast are very rare, but as a matter of fact, they keep the pathologists really busy. And here's what I call the invasive lobular breast cancer paradoxon. Although most pathologists agree on the fact that the diagnosis of ILC feels straightforward or easy, the inter-observer consistency on this diagnosis without support of ancillary tests like E-cation immunohistochemistry or CDH1 sequencing is not quite perfect. This has recently been shown in a study that was supported by the lobster pot action. It is true that the inter-observer consistency increases dramatically once we all use E-cation immunohistochemistry. But it is also true that the results of this study was not a big surprise to experienced pathologists, because pathologists actually also know that ILC is like a chameleon. ILC can behave like a chameleon. In addition to classical ILC, which is easy to recognize, there are approximately 15 different morphological and biological variants that have been described in the scientific literature. And some of these variants are quite difficult to discern as being ILC at all. In extreme cases, invasive lobular breast cancer can even switch from a non-cohesive pattern to form focal tubular elements. For breast cancer diagnostics, this is an extremely important morphomolecular phenomenon that is apparently based on the upregulation of placental p-cadherin as a partial substitute for defective E-cadherin. To illustrate this unusual capability of ILC to behave like a chameleon, I have taken along a very interesting case that has recently been submitted to our reference pathology unit. This case corresponds to a 52-year-old female. She was diagnosed with invasive lobular breast cancer in a needle core biopsy from the breast 5 weeks before. And while she was waiting for her breast operation, she developed gastrointestinal complaints and underwent a coloscopy. And the biopsy was taken from the mucosa of the large bowel. Shown here is the histology of this bowel biopsy. It turned out that the normal mucosa of the colon, which is represented here by the somewhat larger glandular structures, was infiltrated by tumor cells that grow in tubules. A direct comparison of the tumor biopsies from the breast and the colon showed two completely different growth patterns. In the breast, there were small tumor cells growing in single-file linear cords, as ILC usually does, but in the colon, there were cohesive tumor cells with plenty of cytosol growing in tubules. The local pathologist couldn't classify the lesion in the gut. They realized it's not a typical colon carcinoma, but they couldn't say what it actually is. They suspected maybe some kind of an ovarian tumor or an adenocarcinoma derived from the Wolffian duct. But because they were unsure about this, they submitted it for a second opinion consultation. And interestingly, it turned out that both tumors were estrogen receptor positive and E-cadherin negative and shared the same CDH1 nonsense mutation, a somatic mutation, by the way. The germline was wild type. My reference diagnosis was metastasis of invasive lobular breast cancer in the gut forming tubular elements. The local pathologist called me and said, this diagnosis is nuts. But a few weeks later, they called me again and apologized for their comment and said, okay, now we realized it's really ILC in the gut. What had happened in between and what had convinced the other pathologists? It is always histomorphology what convinces the people, because in the meantime, the patient had undergone colectomy, which is a resection of the large bowel to reduce tumor burden. And the colectomy specimen revealed that in the deeper layers of the bowel wall, which are highlighted here by this arrow, in the deeper layers of the bowel wall, which could not be sampled in the coloscopy. In the deeper layers of the bowel wall, the tumor cells were growing in a perfectly non-cohesive manner, as ILC usually grows. But when the tumor cells invaded into the innermost layer of the bowel wall, into the mucosa, the only layer that could be sampled during coloscopy, they suddenly switched their morphology and started to grow in a cohesive manner and form tubules. Immunohistochemistry performed on this colectomy specimen showed that in all layers of the bowel wall, the tumor cells were always estrogen receptor positive and E-cadherin negative. In the right figure, please don't miss the actual tumor cells. They are E-cadherin negative, and that's why they are highlighted by these arrows over here. And what is stained positive for E-cadherin? This is the normal colon mucosa. Those are the colonocytes in the crypts. A third immunohistochemical staining then showed what we had already suspected, namely that the tumor cells in the deeper layers of the bowel wall were completely negative for placental P-cadherin, but as soon as they invaded into the mucosa, they turned P-cadherin positive and started to form tubules. Now, if you would like to implement histomorphology as an inductive method, the way Virchow and Foote and Stewart did it, you might have to come up with a new hypothesis here, and this is that obviously the tissue microenvironment in the colon mucosa can drive competent ILC cells to express P-cadherin and change the morphology towards tubular elements. Now, this is actually the last slide of my presentation, and I hope that this clinical case has shown to you what histomorphology is for us histopathologists. It is certainly not using artificial intelligence to score anything. But for us, histomorphology is applying basic principles, comparing samples, answering questions from clinicians, patients, and other pathologists as well. And importantly, histomorphology is also always about handling and managing the unexpected. Well, I would have liked to include a third topic about testing endocrine tumor response, but as a matter of fact, the time for this presentation is already over, and that's why I would like to summarize just a few simple key messages. First, histomorphology is a method, and this method is of great value for science and patient care. Second, the spectrum of lesions in diagnostic breast pathology is broad. ILC is one topic, but it is an important topic. The diagnosis of classical ILC is straightforward, but the diagnosis of certain ILC variants can be challenging. Importantly, and this is my third and last point, and I would be happy if you could remember this, breast pathology cooperates with clinical oncology, and together we can guide patient treatment. I would like to thank you very much for your attention. Thank you so much.